Good morning. My name is Dr. Stuart Holden. I'm a clinical professor of urology and associate director of the Institute of Urologic Oncology here at UCLA. Before I begin my talk, I'd just like to give you some definitions of terms. I am a urological oncologist, which means a urologist who has had special training and specializes exclusively in cancer of the urological and genital tract. This is in a little bit distinction with other urologists who subspecialize in areas like pediatric urology and female urology. The IUO referenced on this slide is the Institute of Urologic Oncology, and I'm very proud to say that I'm taping this piece today in a brand new building, which is called the Institute of Urologic Oncology, which just opened at UCLA within the last month. The distinct advantage of a building like this, it's going to house all the relevant specialties that take care of patients with urogenital cancers. That's medical oncologists, radiation oncologists, surgical oncologists, and pathologists. And we'll be able to have a complete multidisciplinary approach to the treatment of cancers. Having said that, the title of my talk today is, I've just been diagnosed with prostate cancer, now what? And I specifically did it that way to give you kind of what I see as a consultation, pretty much the same as that I do if you came to my office with a newly diagnosed prostate cancer. I'm going to structure this talk as pretty much the same things that I tell patients in my office every day and try to give you some common sense approach to dealing with this problem. So the first piece of advice I would tell you is do not panic. You need to take a deep breath. No matter what stage or grade or situation that you have been told you have, death is not imminent from prostate cancer. You probably have a greater chance of dying of a heart attack or stroke from the shock of the diagnosis than you do from the diagnosis. So you need to take a deep breath, relax, and gather your assets, and you approach this problem, which has been just handed to you, the way you approach any other problem, whether it's buying a new car, buying a new house, sorting through different opportunities to get a mortgage. You need to do an educational due diligence procedure. And so in terms of getting educated, what I found that most people get educated at cocktail parties. So that 1 out of 6 men in the United States today will be diagnosed with prostate cancer. So it's a fairly good bet that when you tell somebody you were diagnosed with prostate cancer, whoever you tell knows one or more people that were also diagnosed and treated for prostate cancer. And they're very, very willing to give you their experiences and to share with you, all done in a very well-meaning way. But you have to consider that their experimental parameters are that they've had experience with 1 or maybe 2 patients. When you go see a urological oncologist, that person's had experience with thousands of cases and is able to better put your case in context. So while friends are well-meaning and everybody has advice, go see this doctor or that doctor, you should do your own homework. One thing that all people do today is that they go to the web, and that can be both good and bad, depending on which sites you access. When you Google prostate cancer, you're going to come up with a list of different references, most of whom have, or all of whom have paid for those reference slots. And everybody that you find on that site is paying for access to give you a specific message, which may be a great message, but it may not be the best message for you. So I would say do not shy away from using the web, but just have a healthy understanding about what information you get. My recommendation is to go to websites that involve not-for-profit hospitals, such as UCLA website, National Cancer Institute, or a foundation that I've been involved with for many years, the Prostate Cancer Foundation. They have objective information. They're not selling anything, and they just want you to get the relevant information to help you get educated to make a rational choice about your care. Secondly, get a second opinion. What most people do when they hear the term second opinion, which everybody's familiar with, is they get diagnosed by a urologist for one of a variety of different reasons. And the first thing they do when that urologist tells them they have prostate cancer is go see another urologist, who essentially, for the most part, tells them the same thing. And I've seen people that have seen 5 urologists, and they're getting the same information from each one. Ultimately, if you do that, it just comes down to a beauty contest, but you're not really getting a second opinion. Get a second opinion from a different specialty. So if you're seeing a surgeon for your primary diagnosis, see a medical oncologist, or see a radiation therapist if you're considering radiation therapy. and get your pathology reviewed. That's probably the most important second opinion, because all treatment decisions in prostate cancer derive from the interpretation of the pathology, and there can be differences, and those are relevant. The next thing to do is involve family. I always insist when patients come to see me for consultations that they bring a relevant family member, usually their wife. In many men's cases, it's also their daughters, who always take a very active interest in this. Family members have a different perspective than you as the patient. They love you and they have your interests at heart. Sometimes they're not dispassionate, but it's always good, given the choices you're making, to involve your family, who ultimately will support you in your decision and make you feel more comfortable with whatever it is. And last, I would suggest get a quarterback. Pick somebody in your family, probably not you, that collates all the information and keeps records of the various visits with the doctors. So when it comes time for decision making, you can put all that information together in an objective way. Find that patients who are anxious after newly diagnosed cancer rarely remember anything that you say to them, but the family members often do. So let's put prostate cancer in some context. If you put it in even a larger context as what's on this slide, in the United States, it's anticipated that 1 out of 2 men and 1 out of 3 women will get cancer of some type in their lifetimes. That's a staggering number. So that if you get diagnosed with cancer, it can be somewhat comforting to know that you're in good company. Lots of other people have faced this problem. The results are dramatically improved across the board for almost every cancer today. So there's been a lot of progress since the initial war on cancer was declared in 1971, and that goes across all areas. I'm proud to say that one of the most significant areas is in prostate cancer, where the death rate has fallen dramatically by over 30% in the last 10 to 15 years. So prostate cancer is one of the real success stories, although we're far from understanding everything we need to know. So prostate cancer is the most common non-skin cancer in men, and it's the second leading cause of cancer death in men, the first being lung cancer. 1 in 7 American men will be diagnosed, and 1 man dies every 12 minutes. That's a shocking number. But what's really shocking is that 30% of men over the age of 50, if examined, will have prostate cancer. Now, those data derive from autopsy studies where men die for other reasons, and during an autopsy they look at the prostate, and the autopsy figures show that about 30% of the population over 50 have some prostate cancer. That's a staggering number when you think of it, probably somewhere in the 10 to 15 million range in the United States. But despite that, we have 233 cases diagnosed in the United States every year, a relatively small number compared to 10 to 15 million, and approximately 29,000 die each year. So if you put the numbers in context, a very small number of the patients who actually have prostate cancer actually die of it. And that's something, when you're thinking about your issue, you should keep in mind. Beyond that, the survival rates in prostate cancer are amazingly good. It's, as I said, the most common non-skin cancer in men, but if you look at the overall survival of men diagnosed with prostate cancer, and this is at all ages, approximately 99 to 100% of them live 5 years. At 10 years, approximately 90% are dead, and at 15 years, about 76%. Now, that's somewhat skewed by the age of diagnosis, and most of the people that actually die with prostate cancer die of something else and not prostate cancer. So that's another fact that you should keep in mind. The actual 5-year survival rate from prostate cancer, if you have localized prostate cancer, which we'll talk about in a minute, which is about 80% of the cases, is 99% 5-year survival rate. If you have regional spread, or spread outside the prostate but not to a distant area, it's 90%, and men with distant metastasis have a much poorer survival rate, about approximately 30% for 5 years, but those constitute less than 10% of all the cases. So my job as a urologist is determine the probability that your cancer is either localized to the prostate or is outside the prostate, because all the treatment decisions derive from that. We do that in a variety of ways. The first is by looking at your PSA number. PSA is a controversial test today because it's been involved with screening for prostate cancer, and there's all sorts of things being written about that. There's some good aspects to it, some bad aspects. But once you're diagnosed with prostate cancer, PSA becomes the most valuable tumor marker of any that exists in all of medicine today. The PSA number will correlate with the activity of the cancer and the degree that the cancer is potentially spreading. So that the PSA number, if lower, is generally considered to be a much more favorable situation. The Gleason score is something you also come about, and that comes from the pathology report. There are different patterns of glands. There's a 3 pattern, a 4 pattern, and a 5 pattern of glands, 3 being the most favorable, 5 being the most unfavorable. And when a pathologist looks at your pathology, he determines what's the primary pattern of glands that he sees. That's the first number in the Gleason grade. And what's the secondary pattern he sees, that's the secondary number. So that the majority of patients that are diagnosed have Gleason 6 cancer. That means 3 plus 3, which means that he only sees pattern 3. So the primary and secondary patterns are 3. Pattern 3 plus 4 is primary 3 glands with a secondary 4 equals 7. But more importantly, primary pattern 4 with a secondary 3 is also 7, and that's a much more aggressive cancer than the reverse. Gleason 8 and Gleason 9 are considered to be much more aggressive cancers and behave differently. The next thing is the T stage, or the staging of the cancer. And that's the cancer, if the Gleason score is the biological potential of the cancer, which the higher grade Gleason grades have a higher biological potential. The T stage is the degree to which that biological potential has been realized. In other words, if a high-grade cancer has the potential to spread, the T stage, or the stage, tells us whether it has or in fact not spread. There's many new tests coming on board today, which you'll be reading about and hearing about, called molecular testing, which are tests that are different, measure different things than PSA, and are becoming and increasingly important in both determining the behavior of cancers and also helping to design individualized or so-called precision or personalized medicine. Also, we rely somewhat on imaging in certain situations. There are times the prostate cancers generally spread to the lymph nodes or the bones, so we often use PET scans, CAT scans, MRI scans to determine whether or not it spread to the lymph nodes, and we used metabolic bone scans of various types to determine whether it's spread to the bones. So once you've had this staging, you have, and your doctor tells you that you have a very high probability that your cancer is localized. You then basically have 2 choices, and this is somewhat unique to prostate cancer, although it's gaining a lot of acceptance in various other cancers, where a lot of the cancers that are detected come from screening rather than some particular abnormality. So you have the first, which it should say active surveillance, that's a typo on the slide, versus definitive therapy. So you have the choice of not having treatment immediately if you have very favorable characteristics of your cancer. It's something your doctor should discuss with you. This is also being adapted in other cancers, such as kidney cancer and breast cancer, and all the cancers where many of the cancers are detected by screening. So your choice, if you have very localized prostate cancer, depending on a lot of different factors, is either get treatment now or have active surveillance. So what is active surveillance? First of all, it's not a new idea. It was first discussed in 1960. I'm proud to say by the man who was my mentor at Memorial Sloan Kettering Institute in New York. The rationale is that the vast majority of prostate cancers are very low grade, very slow growing. They occur in older men who are at risk from dying from other things, and therefore it may be that you have a very low probability of dying from prostate cancer if you do not have immediate treatment. And so the question is, are you a candidate for that? A lot of it has to do with what are the characteristics of the cancer, what's your age, whether or not you're a healthy person or an overall sick person, what's your chances of so-called comorbidity or having advanced diabetes or advanced heart disease or having a prior history of stroke or having other blood dysfunctional things, other things that may be more likely to affect your overall longevity than prostate cancer. So that's a determination that has to be made in conjunction with your doctor. And the question is this treatment right for you? This treatment is not not new, as I said. There have been thousands and thousands of men who participated in these programs over 10 and 15 years. And for the right, well-chosen patients with what we believe are very unaggressive cancers, it seems to be safe. In following these patients over 10 or 15 years, very few of the patients have actually progressed to the point where they actually die of prostate cancer. About a third of them ultimately require treatment. But this treatment is definitely not for everybody. There are many people who are emotionally not suited to deal with the concept that either have a cancer diagnosis and are not doing anything proactive. It doesn't fit everybody's emotional family situation, and it's definitely not for everybody. But it may be for you, and it's something you should discuss with your doctor. I might mention that active surveillance is called active surveillance because it's not we diagnose you with cancer and then we wait to see what happens. It's active because it requires every year a repeat biopsy and very close monitoring to determine whether your cancer is what we call a rabbit. In other words, whether it's rapidly going to progress and bolt out of the prostate and potentially spread, or it's a tortoise, which is very, very slow growing and really poses no threat to you. Some people call them tigers and pussycats. Both metaphors work very well. Here at UCLA, we have an active interest in ongoing research in active surveillance and have a very large program, which if you're considering, you should become more familiar with. So if you have treatment, if you have localized disease, but you're not in the most favorable category, or you're not amenable to active surveillance, you should have treatment. The treatments for localized disease generally fall into two categories. One on the left is surgery, of which there are two types, and one on the right, which is radiation, of which there are multiple types, more than two. And the question is, which is the better treatment? I don't think anybody today can answer which is the better treatment for a reason I'll tell you in a minute. But the better question is, which is better treatment for you? And that depends on lots of different factors. Other illnesses that you might have. You may have serious heart disease, not be a candidate for surgery. You may have a cancer that's not likely to be localized even though we think it is, and you may want to have not a surgical approach. So this is a complicated decision. But the reason that we don't know which is better, and the reason why there's been so much controversy going back more than 100 years, is that if we diagnose you with prostate cancer and then we do surgery on you, we're going to find out precisely what that cancer looks like because we're going to have the whole prostate in our hand, send it to the laboratory along with the lymph glands and the surrounding tissues. And many times when you do that at surgery, the cancer becomes more extensive than you would predict by the random biopsies that are done at the time of diagnosis. So that many times the surgery is so-called upstaged. Surgery upstages the cancer. When you have radiation therapy in one of the various types, you're going to take the information that's present at the time of diagnosis, even though it may be underestimating your cancer, and you're going to go ahead and have treatment. So that in comparing the outcomes between surgery and radiation, it's not really fair, and it's not really comparing apples to oranges. Everybody would like to see a so-called randomized prospective study, which would mean finding 100 men with exactly the same characteristics as your cancer and randomly assigning half to surgery and half to radiation. That study has been tried for many, many years. People are still trying to do it, but it's very hard to randomize people and tell them that the study is going to determine which treatment they have rather than their own decision. So it's been very hard to do that. If you decide to have surgery, which is clearly the most definitive way to get rid of the cancer, you have to assume that if it's localized to the prostate and you take out the prostate, that should be the end of the story. And in prostate cancer, as I mentioned, the PSA is a fabulous way to determine whether the treatment has been successful. If you have a localized prostate cancer and it's completely removed surgically, your PSA should be undetectable after the surgery. If it's detectable, then we know there's cancer or prostate cells left behind, and we may have to consider additional forms of therapy. There are two kinds of surgery. There's open surgery and robotic surgery. You'll hear a lot about that. Hospitals that have robots, which are expensive, tend to promote the use of the robotic surgery. Places that don't have it promote the use of open surgery, which has been around over 100 years. There's a large debate as to which is better, and that'll go on for a long time. My own view, as having had a large experience with open surgery over 40 years and a large experience with robotic surgery over the last 10, I think the outcomes are pretty much the same because basically you take out the same thing, you just use it a different way. But the real advantage of robotic surgery is that I think it's not even arguable that the recovery is much quicker and the side effects are much less with robotic surgery, at least with respect to the surgery. Of radiation, there are multiple types. There's the traditional type, which is external beam radiation, which is like having your picture taken, with so-called IMRT, which is intensity modulated radiation therapy with a higher booster dose to the prostate. There's also a so-called dose-dense way of doing it, where you have the treatment, instead of 6 or 8 weeks, you have it over a short number of days, which is something that's being pioneered here at UCLA. In addition, there's ways of doing radiation by implanting radioactive seeds into the prostate, or there's ways of doing it with proton beams. So there are a variety of different ways to do radiation. There's really no data that suggests one is better than the other in terms of radiation, and there's certainly no data that suggests that radiation is better than surgery, but I think if you carefully examine all the variables, you'll be able to come to a decision as to which is better for you. So what if the cancer is not localized to the prostate? We can determine that with pretty high probability based on the staging test that I've already shown you. And we try to distinguish whether the cancer is locally outside the prostate, in other words, confined to the area immediately around the prostate, or its metastasis, which is spread to a distant area. We're pretty good at determining that, not 100%, but we have some really wonderful diagnostic tools to try to determine that. So if you have local extension, the one thing that you understand that it's very rare that one modality of treatment can cure you. If you have surgery and the cancer is outside the prostate, it's very common that you'll need radiation therapy afterwards. And if you have radiation therapy, it's very common that you'll need to have hormone therapy in conjunction with the radiation. So you're going to require multimodal therapy. There's also several new options that are being developed, which are so-called neoadjuvant treatments. What I described to you is if you have radiation after surgery, it's called adjuvant therapy, which means it follows the principal procedure. If you have neoadjuvant, that means it's done prior to the principal surgery or principal treatment, whether it's radiation or surgery, and that could be the use of various biological agents in conjunction with hormones prior to radiation or prior to surgery, and those are being evaluated today. Now, one thing to keep in mind, I guess the take-home message of this slide is that local extension is still curable. It just takes more treatment to get there. So I guess the bad news is that metastatic prostate cancer is still the principal cause of death for those patients who have metastatic prostate cancer, and it's incurable. That means we can't eradicate every prostate cancer cell from the body, and that we have to treat them systemically. That means with a treatment that gets every place, because we don't always know exactly where the cancer is. But the good news is that today prostate cancer, even when metastatic, is controllable. And the strategy of today is to try to do what was done in HIV. We can't always control and eradicate every HIV positive cell from the body, but we can get it to a position where there's so few that it's a controllable disease. And that's the goal of treatment of metastatic prostate cancer today, is to convert it, rather than acute disease, which kills you in the first few years, to a controllable disease, which we can string out using a variety of different therapies over a longer period of time, and hopefully continually develop new strategies. So there is a huge reason for hope, and I think this is the message of this slide. In the prior 40 years, up until the last few, there were very few new drugs that were ever developed for use in prostate cancer, and they basically all did the same thing. They removed testosterone. And there really hadn't been anything new until the last 5 years, when I put 7 new drugs, but actually if you're clever and you look at this slide, there are actually 8 on the slide. It's a typo that I didn't notice until right before this presentation. But all of these medications in the last few years have been approved for treatment for advanced prostate cancer. Zytiga is a novel form of hormone therapy, which recognizes the fact that the testosterone, even though it's removed from the blood, is also very active within the prostate cells that remain, and it's a novel way. It's an oral medication. Enzalutamide is a treatment actually that was discovered here at UCLA by Dr. Charles Sawyers and Michael Chung, and it's now an approved drug. It has a way of treating the so-called androgen receptor which is the thing that drives PSA production and is the fertilizer for prostate cancer cell growth, and that is now approved. Provenge is the first vaccine that's ever been approved in cancer. It was approved for the use in prostate cancer. I would say that it's a modestly effective treatment, but it has definitely opened the door to many companies that are developing more specific and more effective treatments for prostate cancer and other cancers with immunotherapy. Taxotere and cabazitaxel are both chemotherapy drugs, and the ones on the right side of the slide, Xgeva, or its other name can be Prolia, Zometa, are used to mitigate the side effects of androgen deprivation therapy, in other words, taking away the testosterone, which causes bone loss and bone fractures, and these drugs prevent that. And the last one is called Xofigo, which is an alpha-emitting radiotherapy drug, which provides radiation therapy directly into the cancer when it's in the bones, and it has very little consequences and toxicity of the type that many of the other radiotherapy agents have. So these are all new drugs. The biggest problem we have today in the field is learning how to incorporate these new drugs into our treatment paradigm. But I would submit it's better to have the problem of figuring out how to use 8 new drugs than not having any drugs to use. So that's kind of consuming a lot of our time today. And finally, I would say, again, establishing the value of hope for patients even with the most advanced situations. The prostate oncology pipeline, based largely on the success of the prior drugs that I mentioned. Success tends to breed success. And now the prostate oncology pipeline in biotechnology and pharmaceutical companies is extremely full. There are 35 new agents in production. 40% of them are in phase 3, which is the last phase prior to approval, which compares a new treatment intervention to the standard of care. And we believe that many of these drugs will clear the hurdle and be approved for use. And most excitingly, from my perspective, is that 40% of these new drugs are immunotherapy, which is capitalizing on new information about how the immune system works. And I believe this is a very exciting area, and there's huge interest in combining immunotherapy with some of the other modalities that we currently use in prostate cancer with a high degree of probability that they'll be very effective. So that concludes my talk. Hopefully this gives you a framework for thinking about prostate cancer. And obviously, if questions arise, you are free to contact us here at UCLA, and we'll try to answer your questions in the best manner possible. Thank you for your time.